Thank you, Madam Chair, and thank you all for all your work you're doing here. I don't need to restate some of just the statistics, and we all say that one veteran suicide is too many. I know that many of you mentioned just some of the assessments that I think, Ms. Meyer, you mentioned that only 6 of 180 of the assessments were complete. And just reading the list of requirements of all the different scales and assessments you have to complete, I know we can get bogged down in some of these screenings, especially things like I quickly reviewed the Columbia Suicide Severity Rating Scale and can understand it. I'm a nurse practitioner, did primary care, so really assessing patients' mental health. It's I understand the importance of the scales, but there's a job that we're trying to do, and getting bogged down in that type of scales, it just seems like we've expanded government yet again and the requirements for you all. One thing that I didn't, so there's I think a discussion we had about, do we really need all of those scales? Because you know pretty quick if you're dealing with somebody who's in trouble and who's not. And one of the things that is not listed on these scales that I'm interested in, just from talking to veterans in my district and understanding depression and suicide, is are we ensuring, and I guess this is a question maybe for Dr. Scavella or Dr. Burnett, but ensuring that we're looking at their med lists and what these guys are taking, because I know that you talked about talk therapy and all the other components of and the scales and everything else, but there's so much that chemical imbalance. And I have seen firsthand, time and time again, when we administer medication to these patients, and most of them carry black box warnings about the increased risk of suicidality. And I have seen it like night and day, like flipping a switch. And I usually would have my patients come back a week or two after we start a new medication. Are you feeling better? Are you feeling worse? Do we need to change course? Are we looking at that too? Is that one of the assessments that we're doing? Because I don't feel like we've talked about that a lot.
Yeah, so thank you for that question. One of the things we do at every visit is medication reconciliation. So we're looking at the medications they're on. We're also questioning whether or not they need to remain on something they may have been on for a while. Mm-hmm. Can we reduce the strength? Can we reduce the frequency? Can we discontinue it altogether? So those are questions that our clinicians are asking at every visit. Looking at potential side effects from medications that they're currently taking. Yes, that is something that is included. And we don't just have our clinicians who are involved, but we have a group of clinical pharmacists who are also part of the care team, who are also doing that look to assist our clinicians with those assessments and those reviews.
And is that being done in some of our other care organizations, that the rest of you guys just not leaving out that medication component? I've heard even from Special Forces guys that say, we got a bag of medications. Their spouses would say, we found this bag of drugs. We don't know what it is. We don't know what it does, but this was given to them by their team doctor or by their, so just making sure we're having those frank conversations about what medications you're ingesting. Do you know what they're for? Do you know what they're called? What side effects they carry. So are we looking at that from the other side too?
That is not something that we're currently assessing. We do not employ any clinical staff.
So as a clinician, that is something that I look at, and our staff are trained to look at as well, because it is instrumental in determining risk factors associated with veteran suicide. So,
how about you, Mr. Falke?
We do look at medications as part of the intake summary, and it's been amazing to me. We had a colonel in one of our programs, a retired colonel, who's on 34 different medications. So it's been super disappointing to me. But I think, I know how it goes. I'm a patient at the VA as well, so I know how it goes. And you just get one drug after another, and you start to store them up and take them. So, but we do look at it very closely.
So in my perfect world, I shorten this assessment list that you guys are required, and I put in a medication assessment by a clinical provider who can understand those interactions and some of those side effects profiles. So thank you for that. Let's see, also for Dr. Scavella and Dr. Burnett, for just continuity of care, I feel like is a really important piece that I feel like when we have our initial assessments it's a team effort by some of our other care organizations, is the VA doing a good job with that continuity of care piece? Because that's where we lose people, and we get them either inpatient or, these initial assessments, we get them, but then we lose them. So can you talk to me a little bit about what that looks like?
Yeah, so care coordination is really important. We reach out both internally and externally when our veterans may receive care outside of our actual system, to make sure that we have all the information, that we can do the proper follow-up, and also if it's vice versa, they're leaving us to go somewhere else, to do the same thing. Is there anything you would like to add, Dr. Burnett?
And do your other care organizations provide continuity of care pieces as long as needed?
One of the things that we've really talked to the VA about is how do we get most of the people that come to us don't go to the VA. So what we want to do is make sure that they get over there, and that's really what I believe that we make our participants better patients. And that's one of the things that happens is you lose agency and you start to believe things, and that's why you take drugs that maybe you don't need. So to put a patient who's been through our program into the VA with better agency and better to be a better patient, I think it really creates a win-win for this program because it's going both ways.
Very much so. It can't be overstated, and I'm out of time, but thank you very much for all that you do.